sort of a preterm baby is also normal preterm who has not had any kind of problems of prematurity, who has developed normally. I see this child first for the refractive check after 6 months. But children who have had either a laser or they have had some kind of surgery, I refract them generally within 2 months from doing the procedure.
Professor Sharma Eisenberg for choosing this instruction course for actually delivering one of his guest lectures. When we submitted the course, we were not actually sure whether we should submit it or not. This is the first time we've been doing imaging in babies. Bad enough. Pediatric is a very narrow field and there is very few instruction courses that get accepted. We're very happy. We're even more thrilled that Professor Eisenberg wanted to speak through this course. And I also want to acknowledge the presence of Professor Madam Miller and Professor Del Monte from Illinois and Michigan, who are here. We're very honored to have your comments in this session. The idea here is just to talk about what recent advances have happened in our ability to image what so-called normal-looking babies, especially normal-looking retina, otherwise not normal. And so I'm outlining my talk into 3 parts. One is imaging the unseen, which helps us see better. It's kind of paradox there. And imaging the image, which is going to be some experience we've been having with software analysis. And the third is going to be just a few cases of explaining unexplained visual loss, again, kind of a paradox. So I think part of my talk is going to be on OCT, because the webcam we read in the previous session. And pediatric OCT, infant OCT has come of age now. And before, borrowed those pictures from C.K. Patel and others in the United States have also shown this used to be called flying baby position, where you had to literally take in those days, the time domain OCT with the OR and laterally or supinely the baby. But today, with modifications either of regular handhelds or the availability of the handheld OCT, we're able to image that part in the OR, in the clinic, in the office, without anesthesia, things that we were not able to see. So the first thing I want to bring to your light is that we know so well this adult OCT picture. We know the layers, we know what's inner and outer retina is marked in blue and red here. But it's interesting to know that infant OCT is not the same. All of us, especially if we're born premature, don't have the OCTs of, let's say, our adult, even our parents. And that's something I want to bring here too. So this is the inner retina, and what happens in an immature retina is this outer plexiform layer. First of all, it's an easy thumb rule. So whenever you're looking at a spectral domain OCT, the white lines are plexiform, and the black lines are nuclear. So this would be the outer plexiform, and this black would be the outer nuclear, and so on. So this outer plexiform layer is not touching the inner retinal layer. Just go back to the adults. You see, this is what we call an inner retinal migration. There are many theories of why this happens and when it happens. But it must happen. If it doesn't happen at the correct time, children tend to have poor vision. So this inner retinal immaturity is one of them. The second thing is an important layer is the external limiting membrane, the lightish gray one there. And then I'll go back to the adult again. You see this foveal tint. So this inner segment, outer segment, which is the whitemost line here, has a little bit of a hump there and a little more blackened area there. That's because of the longer cones. The cones actually have longer cilia than the fovea, the subfovea, and that's what actually pushes this up. This middle layer is often not given a name in adult OCT, or is called the COST, or the cone outer segment terminal. However, in pediatric OCT, and a lot of this work is done at Duke University, we actually have a name of another layer which is called the OSRPE, or the outer segment RPE. So it's really in between the ISOs and the RPE. So let's look at how we can use OCT to actually map some visual changing. That's what really gets us working, how we can predict vision. So this is a premature baby born at 38 weeks. And now what you see here is just the RPE line. And what I want you to see, and I'm going to play these next few slides in rapid succession, it's going to be like a flip book. So you're going to start seeing this blue, 2 arrows start converging. And what that's going to show you is the inner segment, outer segment actually comes in from the out. So it's really a centripetal migration. So here it is, at 38 weeks. At 42 weeks, it's coming closer, but it's still not two distinct layers. At 46 weeks, it's almost coming closer. Also notice that the outer plexiform layer is fusing. And then at about 47 or 48 weeks, that's what studies have shown. The average is about 48 to 52 weeks. That's the third corrected month for premature babies, is when you will get a double line. And then, of course, the foveal tent is something that happens even much later. Here it's at 48, it's completely fusing, you see a 2 lines. This is serially mapped on the same baby using the same device. So we actually serendipitously discovered this when we were actually trying to map NDEs of ROP. We were also mapping obviously the foveas, and a clinically normal looking fovea. Of course, this eye had a stage 2 in the zone 2, and this eye had stage 1 in this example. And what we found is about 30% of stage 2 ROP babies ended up having these foveal disruptive changes. Now, we did not call it cystoid macular edema. It was very tempting to do that. It resembles the adult sleeping forms. But because we simply didn't know what character these had and what pathology they carried. But what we found is we found two distinct patterns in this. So we called it pattern A and pattern B, and we characterized that. And basically in pattern A, you have a complete foveal dip disruption and with large cystic spaces. And in pattern B, you have some amount of the foveal dip preserved and cystic changes. It could be a milder version, it could be one that's seen much later. But what we noticed is both of them are self-resolving. So by the 52nd corrected week, which is the third one, they seem to completely go away. So what influence that could have on vision in long term is something that we've been studying now, and some of that is what I'm going to share with you. So what are the layers in a fovea, especially in the developing, evolving fovea, that code for vision? So the first one, this is again, we just saw this baby. In our setup, we do at the third corrected month, we start assessing their vision and their refraction for premature babies. So this is a 3-month-old baby, quite 20 by 1,400. In our nomogram now, we know that's less. At 3 corrected months, they should at least see 540 or 670 on telemetry, done in our settings. Again, a 3-month-old baby who had normal vision for that age. And so we looked at the OCT to see if it will tell us something, and you can immediately see that the inner retinal layers have not fused, and that's the star. That means the outer plexiform layer is quite far away from the inner limiting membrane, whereas here they have fused. So inner retinal fusion, we found, was a very important indicator that they would have better vision early. And then, of course, you see that the one, that line, this is the inner segment, outer segment not coming to the center, but here coming beautifully to the center, a bit of the OSRP as well, and even some tent that seems to be developed. So then we did, of course, this was retrospective, and now we're just completing our perspective data. And so the plus would show you which layer was positively influencing vision, statistically at least. So we found that the inner retinal layer migration, is the same example, has better vision. And the earliest we saw this fusion was 3 months, and the oldest case in our cohort, now 18-month cohort, was 9 months when they did not have fusion and therefore poorer vision. We were also able to image the external limiting membrane a little earlier than the group. We used a different protocol and a different device, but we think that between 41 and 45 weeks is when the external limiting membrane should appear, and the appearance of that codes very well positively for vision. We then found, of course, that interestingly, the inner segment, outer segment, which we are so accustomed to thinking codes for vision, especially in adult, let's say, macular hole surgery, where some amount of prognostication is made just based on whether AIOC is present or absent before surgery. Interestingly, we found no correlation. This is not a negative correlation. It means we did not find a statistical correlation between this layer and vision. Interestingly, we found the outer segment RPE, which is that jelly-like, a shading layer, which is now a very distinct layer in this picture. We found that to code positively for vision. And of course, the earliest we saw that happen, the USRP, was 6 months, and even at 9 or 12 months, it sometimes did not happen. Then we looked at the sub-cohort of babies who had retinopathy of prematurity and looked to see if ROP is delaying some of these layers and therefore indirectly or directly affecting vision. And we found two things. One, ROP negatively correlated with the presence of the later presence of external limiting membrane and the inner segment, outer segment layer. Now, one of them codes for vision, one of them doesn't. So now we're very keen on following these babies prospectively to find out what happens. This is the external limiting paper. So the summary of findings in terms of the OCT layers and vision was there seems to be a positive correlation with inner retinal fusion, external limiting membrane and the USRP. There's no correlation, interestingly, in eyes towards a negative correlation with the presence of ROP. The Second part of my talk is just to introduce you to some of the very interesting work we've been doing with some biomedical engineers. We're taking regular RED-CAM images and trying to non-invasively pick up information of the vascular tree. Now, of course, we can do this with an angiogram, but we're just blessed with the RED-CAM shuttle and we're not able to do that. So we're just wondering how we can pick up better vascular information. So this is, of course, a patent-pending image processing tool that they use. It's indigenously developed. The original photo that hardly shows you where the edge of the flat neovascularization is, a color enhanced which actually shows you that, a gray enhanced, and then this is the more interesting one, which is the vesselness measure. Just let's take one example. This is zone 1 aggressive posterior ROP. It's the right eye, fovea somewhere there. You really see the vessels have not even reached the center of the macula. And what we're trying to look at is by getting this kind of a vessel nest protocol, are we able to detect vessels beyond where they are seen on the naked eye? And therefore, maybe, we can actually recharacterize and re-diagnose these patients from zone 1 to maybe even posterior zone 2. And we all know what a huge difference that makes in terms of the management decision and the prognostication and even how they do for treatment. As we know, Flynn group has described what the difference between vasculogenesis and angiogenesis is. So we're trying to see if we can match vessel anatomy picked up this way. We look at two more examples of occluded venous red in this child who was just a few months old. You can probably see it better here, these occluded vessels in the color enhanced picture as you wouldn't have seen it in the original picture, and you see the complete absence of capillaries and the dropout there in the vesselness protocol. And then this was a CRAO, a bilateral retinal artery occlusion. We saw in a 4-year-old with nephrotic syndrome. We know they have hypocoagulable state. This was a severe retinal artery occlusion, so the child did really well. But this is not the angiogram picture. This is to show you that some amount of capillaries are actually there in the center of the fovea. We saw a map which was consistent with the sparing of the severe retinal artery. I'm going to conclude with 3 or 4 cases that, this is where I shared with Dr. Ashwin, cases that we've been looking at in the clinic, doing their OCTs, and then matching what we find with the electrophysiology. This is a 7-year-old female now with a refractive error, as you would agree, here is not very big. And the vision is much lower than what it should be. And of course, the parents are cousins, so there's a lot of consanguinity in our country, especially in the state that I come from. And 2 other siblings seem to be normal. There's an intermittent divergent squint. The fundus and color vision are normal. There's not much we know. These are co-shared patients. So if you do an OCT, and now from the knowledge that you know already, the inner segment, outer segment is completely eaten up here right in the fovea. There's a presence of an external limiting membrane. The IR inclusion seems to be good. There's almost no tall cones here. So the inner retina seems to be normal, but there is a disruption and loss of fovea 10. The cone vision in the fovea seems to be depleted. So interestingly, a full field ERG was almost normal with minimally reduced and a bifid B wave in the photomic white flash. So this is I'm trying to show you how some OCT findings can be subtle and actually can tell you of a tale that's otherwise not going to be missed. This is the macular integrity assessment of the Maya, as we call it. It works with microperimetry philosophy. You see that's the scotoma, that's a depressed sensitivity right in the fovea center, otherwise doing well. That's like a sea of darkness, island of darkness, a sea of otherwise good vision. But that's troubling the patient. That probably explains the 616 and 618 vision. Again, in the left eye, that central scotoma. So we go on and do a multifocal ERG, this is what Ashwin did, and of course it shows a central reduced response between the first 5 degrees with the reduced light P. So again, probably early cone dystrophy. Just trying to show you the synergy between OCT and other tests that we routinely do. Again, this is the right eye of a patient, 6x6, that's the refractive error, and you can see it's a very healthy, normal OCT, a 7-year-old who's been labeled anisometropic amblyopia. That's the difference, may or may not be, not improving with patching, although compliance has been measured. You see, this OCT intuitively tells you that there is something hugely wrong. You see a not compacted inner segment, outer segment. You see these 2 really far off layers. You don't even know whether this is ISOS or this is DLM, or these are just ISOS that's more skeeting. But the point is that structure is defining some of the abnormal function that we see. You see the outer plexiform layer is not regular here, it's not fused, and the outer nuclear layer almost seems to not be there. So let's look at that left eye a little more deeply. So the marked attenuation of the photoreceptor complex, the ISO is much thinner, wider separation, the outer plexiform is irregular, and an inner retinal anatomy is not even developed. Again, a full field ERG is normal. And cannot contribute to our understanding of this case. So again, could this be a candidate for multifocal ERG, or is it just poor compliance with patching, or is it something else? These are more questions than answers, really. My third case, the 9-year-old, again not improving with patches. It's a bit of a cylinder here, and same, almost the same here, 615 and 618. You see again, this ISOS is so much thicker, abnormal, irregular, patchy, and the external limiting is a little far away, and the outer nucleus is also spaced out. You see these almost nodular-like lesions here. I mean, they're not really lesions, but is this just clumping of the cones, of the photoreceptor layer? What do these mean? How do they, is this just ischemic insults that happen much earlier, and is that why they clump? Is it anything? I mean, these are just questions, but just to tell you, to open the eyes that, otherwise, the anatomy looks normal, the fundus looks completely normal, the full field ERG again is normal. My fourth case is a case where it's again a 6-year-old not improving with patching and with glasses. Again, compliance is measured. What you see here is the outer nuclear is completely thinned out. You almost see no black layers in the center of the fovea. The ISOS is broken. There's an external limiting membrane. There's almost nothing there. You would think that this could be something like a solar retinopathy. The outer retinal folds, the outer retinal changes that you get. And again, the same changes are almost similar, with similar vision in the fellow eye. The ERG report, interestingly, has some abnormality here. It says it's a supernormal scotopic response. The cones are definitely subnormal, and Ashwin had recommended that we do a multifocal ERG on this patient. So really, to summarize, the spectral domain OCT, especially the bedside one, has a clear advantage in helping us better understand and do a better subclinical assessment of these children. Certainly helps us understand the disease process, the natural history better, and maybe soon, with some of the layers prognosticating for some vision and some not, we would have a sort of roadmap to figure out how we can predict vision better in our children. A lot of these images are in the spectral domain OCT text that we brought out. We had several national and international contributors. Thank you very much for being here.
It's a great honor to speak before you here in India. I'm here about every other year to see the research and development purpose. Every year, the food tastes better than the way it is. Okay, along the way, I'll impose upon you my hobby, which is underwater photography, and such as this eagle ray, who, as you see, is very happy to see you all. No financial disclosures, in case any of you are starting to develop a bilateral ptosis. As we continue, this shark will come out and bite you. So everyone, stay away for the next slides. Before I get into the meat of the topic, I want to announce to all of you a wonderful thing that's going to be happening in 2016. AIOC, the American Association of Pediatric Ophthalmologists for Business, is sponsoring now co-sponsoring now international meetings. And our third one in the world in the history of AIOC is going to occur in December in Jaipur, 2016, in conjunction with the Strabismus and Pediatric Ophthalmological Society of India. We encourage all of you to come. And I can't help, when speaking about international efforts, without acknowledging Dr. Marilyn Miller, who's in the audience. She has been the spearhead for more than 20 years of international efforts from the U.S. to other countries, India, Nigeria, and many other places. And also Dr. Del Monte, who was the head of the International Committee of Naples for many years, and helped us also go international. So please be aware of those dates, and hope to see you there. We're going to talk about neonatal conjunctivitis now. Well, what's the definition of neonatal in this context? It's an ocular inflammation arising within 30 postnatal days. It reportedly occurs between 0.3 and 16% of births, depending on what country or region you're talking about. It may be infectious, it may not be infectious. What are the causes? The most feared cause is Neisseria gonorrhea. In the 19th century, this is hard to believe, this is documented. In the 19th century, gonorrhea was the #1 cause in the world of blindness in babies. the number one cause is gonorrhea. Or routes. Something's loose. In many places, such as well documented in Germany, Denmark, it was as high as 10% of all babies developed gonorrhea or conjunctivitis. In the early 20th century, in many countries, it was documented to cause 20% of all children in schools for the blind. Now it was much less, but still, without prophylaxis, the incidence is as high as 23% in Kenya and other places. How is it acquired? Obviously, it's acquired from the birth canal with a transmission risk of about 17% if the mother has it. However, it also occurs from ascending infection from amniotitis, and as we've seen, unfortunately, a number of times, contaminated secretions from an adult hand. The onset is fast. The onset is between day 1 and 21 of life. The discharge arises sometimes a little later. If it's after a week and you suspect this, consider that it's acquired after birth. This will present with the most marked inflammation you have ever seen. And you will have seen in an eye. There's severe eyelid swelling. There's chemosis so badly that the conjunctiva balloons out and beyond the eyelid margins in the worst cases. Copious purulent discharge. And the cornea can penetrate with the necrosis with potential obviously scarring and blindness. It's bilateral in roughly half the cases. And my picture is not coming up. See, there we go. Now, when I tell you copious discharge, this is copious discharge. When you see a child like this, you better wear some glasses or back off. Years ago at UCLA, we actually had a resident examine a baby like this, get his eye really close to examine the baby, pull the eyelids apart, squirt, and he later developed gonorrheal conjunctivitis right into his own eye. So there's a lot of pressure, so be careful when you examine these babies. And the worst cases like this can result in a perforated cornea. The second most concerned cause is chlamydia. This arises in 10% to 43% of cases. Why is it bad? Because cervicitis from chlamydia is found in 2 to 18% of women. Neonates exposed to chlamydia, 28% to 70% become infected. If a child has chlamydial neonatal disease, it most commonly occurs in the conjunctiva and then other areas. This presents in a less severe fashion than gonococcus with mild swelling, but it's more chronic. The chemosis is mild through the hyperemia, papillary reaction, pseudomembranes in the most severe cases, but that takes weeks and weeks to develop. Peripheral scarring can also occur over time. And here's such a patient showing the conjunctival reaction, and you can see a little bit of the pseudomembrane there. It's usually unilateral. It arises later than gonorrhea at about a week. But after 6 weeks, it's considered something else. If it's left untreated, it's self-limiting in some cases, but after 6 weeks, older infants will display prolific conjunctivitis. Younger infants are incapable of developing follicles and they won't show. The thing that we don't worry about, but the pediatrician does worry about, is pneumonia. They tell me that no baby ever died from chlamydial conjunctivitis. Babies have died from chlamydial pneumonitis. And if the baby has it from birth, there's a 10 to 20% incidence of pneumonitis. Sometimes with conjunctivitis, often not. So if you diagnose chlamydial conjunctivitis, you should notify the pediatrician that that's the case. And that's the reason why when it's treated, I'll get to treatment in a second, you have to use systemic medication because of the pneumonia, not because of conjunctivitis. Other causes are viral, such as herpes, with eyelid swelling, contagion, corneal clouding. This you're familiar with. Other viruses are quite rare. And here's a case of a baby with herpes conjunctivitis. Oftentimes, I should mention that, whoops, what did I do? I went to the very end somehow. Sorry. Got a grip. When the baby has viral conjunctivitis, herpes conjunctivitis, often the child is very gang cyclovirus, and other disorders. Other causes are various types of bacteria. You see listed here, both gram-positive and gram-negative. If the baby has a gram-negative bacteria in the eye, often they can have sepsis. That's a concern. Chemical conjunctivitis is something you have to rule out. It can be caused by any of the prophylactic agents, up to about 50% of cases in some studies, depending on how you define inflammation. After 24 hours, it's down to 7% or less of babies that have it. In the old days, silver nitrate was a culprit. Silver nitrate would cause it. Today, silver nitrate, to my knowledge, is no longer manufactured anywhere in the world for ophthalmic use. There was one factory in Germany that was still manufacturing it about 10 years ago, and I've been told it discontinued. So you won't see silver nitrate for the eye anymore. Prophylaxis. An interesting story that I'm going to try to summarize in 2 or 3 minutes. Prophylaxis began in 1880. A doctor named Perdet in Germany discovered that he applied silver nitrate 2%, later reduced to 1%. He decreased the incidence of gonorrheal conjunctivitis in his hospital from 10% of all babies born to 0.3%. This was a milestone in preventive medicine, one of the first great milestones preventing disease ever in history, and it was done in ophthalmology. Silver nitrate was a frequent cause of chemical conjunctivitis, less effective against chlamydia than other medications, and that said, it's no longer manufactured. Some places used to use tetracycline, but it's questionable against chlamydia, and often does not work against Staphylococcus because they're resistant to it. That tetracycline is seldom used anywhere in the world. Erythromycin is commonly used today, especially in the U.S. It is effective against chlamydia. In most cases, but then there are some cases where there's a question based on studies in Louisiana and Seattle, Washington. And it's widely used in Western countries. Povidone iodine that we published about in 1995, as you see at the bottom, today is possibly the most commonly used eye drop in the world for this right now. We proved in a study in California and later in Kenya that it was as good or better than any of the other agents, meaning the erythromycin or silver nitrate. It causes less chemical conjunctivitis. It is way cheaper than these other medications, and therefore it's being used worldwide. Curiously, it is not used in the United States. Since when I appeared before the Food and Drug Administration, they demanded a U.S. trial. The U.S. trial would cost about $2 million US, and no one's going to spend $2 million US on an eye drop that costs about 1 or 2 US pennies per drop. There's no profit in it. No one's willing to pay for it. So the irony is, even though American studies developed this thing, we can't use it in America. But it's being used all over the world, which is funny. We also thought perhaps a second eye drop would help. After the first drop, 24 hours, we would see even a better decrease in bacteria. Also. And in a study, it's a very loose connection. Anyway, in a study that was published in the British Journal, we found that the second eye drop really didn't benefit. So that one eye drop was fine. This recent study, such as this one in Iran, showed that erythromycin ointment versus saline versus nothing, you see the conjunctivitis rate, there's no difference. But another study in Iran from the same year, from a different group, showed that the povidone iodine gave the best results with the lowest incidence of infection. A Canadian study of a meta-analysis study of 8 different studies that showed that against gonorrhea, all these drugs are equally effective, but against chlamydia, erythromycin and povidone iodine are more effective. This is lost. So, what do you do when you have a baby who comes to you that you've made the diagnosis of conjunctivitis? You want to get a history from both parents. You may have to ask them separately. Often one parent will not admit before the other parent can give you the proper history. You want to ask about urethral or vaginal discharges. You want to ask about any genital vesicles, sexually transmitted diseases, and compliance with prenatal care. This instance of this disease is far higher in women without prenatal care than with. Regarding the child, when they ask the onset of symptoms and signs. Laboratory-wise, what do you need to do? You need to scrape down the bladder, really scrape it, not just a swab, but take a caloric fat spatula or some other spatula and scrape to get exudated cells, ram-stain it, looking for gonococcus, looking for other bacteria. You want to do immune sustain for cytological changes, looking for chlamydia, and then you want to do a direct fluorescent antibody analysis or ELISA testing for chlamydia. Depending on your site, you may want to culture using blood agar, chocolate agar, as well as broth. And then there's also, this is not used very much anymore, but there's tissue cultures available for chlamydia. No, I did not do this one. What is the treatment? For gonorrheal conjunctivitis, basically the treatment is one IM injection or one IV infusion of ceftriaxone. If you give it IV, you give it once or twice IM, they'll give it daily for 7 days. But there's been studies showing that just one IM injection alone is often effective against this horrendous looking infection. If you're going to do that, though, you want to use something topical, which says at the bottom here, to prevent membranes and adhesions. So saline solution would be fine, irrigate. Some people use bacitracin solution, irrigate. One of those would be good. The alternative would be ceftaxime IM if you don't have ceftriaxone. If you remember, we talked about pneumonia in the context of chlamydia. That's why we need to use oral drugs and not just topical. So we generally use oral erythromycin syrup, and we'll consider something topical in addition, such as sulfacetamide and tetracycline. If it's non-gonococcal and it's non-chlamydia, pretty much any broad spectrum ophthalmic ointment would be fine, and sulfa's fine, erythromycin's fine, Neosporin ophthalmic ointment's fine, and many of these will work. For herpes, you need ancestral, but often this is in the context of a systemic problem, and the pediatrician will treat it anyway systemic. So, that brings us to the close of this, and I just want to let you know that when I was in Indonesia diving last year, and I saw this very friendly Remor EL, he and I chatted in the water, and I told him that I was coming to Agra to speak to this wonderful Indian audience, and not only was I excited, but he got excited too. Thank you so much for your attention.
Video. So this is, you could have dissociated vertical radiations associated, you could have latent manifest nystagmus, or even manifest nystagmus. In this child, you see there is a nystagmus which is present now. We cover, the nystagmus is increasing, and it is beating towards the left eye now. When we cover the left eye, it will beat towards the right eye, so we cover the left eye. So it's basically beating towards the fixing eye. So that's another feature that we could have in infantile esopropia. And essentially speaking, if you look at the management of infantile esopropia, the first step in management is refraction, and what you need to do is give a full cyclophagic correction, which means you do your endoscopy and under atropine or cyclophagic, you need a strong cyclophagic, you subtract only for the distance, not for the cyclophagia, and prescribe those glasses to the children, and that's the more important portion of it. Then we will come down to surgical management in a bit. Fusion sometimes you can give 1:1 while waiting for surgery, or if there's an amblyopia associated, then you could give a fusion for that. As far as surgery is concerned, the idea is that you follow certain normograms. You need to address the other associated things, let's say like the obliques. When is it that you need to operate? Usually the best time would be between 4 to 6 months of age and up to about a year. If the child is older, when he presents, obviously you need to operate. In all infantile esopropes, need to undergo surgery. The second case that we will present is a case of refractive esopropia. Look at this child is having esopropia. It is the right emergence at the moment. When you give a refractive correction, the esopropia is directly corrected. So this is the case of a refractive esopropia where the refractive correction, again a full cyclophagic correction is what needs to be given. It takes care of the refractive error altogether. And we'll come to a circumstance where there is now an associated residual esopropia which is left, for which surgery would then need to be treated. Again, a full cyclophagic refractive correction needs to be given to such children. The next esopropia that we come to is accommodative. Look at this child having esopropia. You give glasses basically, but despite that, when he's looking for near, he's again having esopropia. But if you see that when he sees through his bifocal segment, which is the near eye segment, the esopropia disappears. So this is classically a case where the accommodation is causing the esotropia. It's an accommodative esotropia, so to speak. And the treatment for such cases, the important thing to remember is bifocals. Of course, you need to give full cyclopedia retraction, but bifocals and how much bifocals has to be given depends upon the AC by A ratio is 1, but also the lowest amount of bifocal that will take care of the esotropia from here. And it's important to show accommodative target. So here we show a Benton, which probably is not the ideal target, but however, let's say we do the land fixation targets or a near chart that would be used. The child has to accommodate an N9 target and that will be used. But there is still a leftover, you could do surgery. If somebody is not willing to wear bifocals or somebody cannot wear bifocals, you could consider another form of surgery that we come to, which is basically a retractable myopexy. But it's not the routine to try. The idea is to give bifocal glasses. The next form of esotropia that we can come to in this case is a convergence excess esotropia, which is again like in accommodative esotropia. This child is wearing glasses. Another thing that is having esotropia, but when you correct him for making him see through the near eye of the bifocal segment, the esotropia disappears. And this is how the ideal bifocal should be given. They should be bisecting the pupil, right? Giving like this does not work because the child will be seeing always through the upper segment and will not be using the lower segment. Unlike an adult that can do such, these effective bifocals are required for children. So it's important to have a segment bisecting the pupil. The last one that I want to discuss quickly is partially accommodative esotropia. Here you see there is an esotropia which is increasing for accommodation. Despite giving the near eye, you can still see there is some amount of esotropia which is left over. And this here you need to do a surgical correction for the non-dynamic portion of the esotropia. Essentially speaking, the portion which is left over now after you've given the refractive correction and you've given the near, in this case only the near correction or a bifocals have been given. For that you have to do surgery which will be again as per the normograms, and in post-op the eye is aligned now even from here. So this is in a nutshell the basic types of esotropia that we will come across and how to manage them.
Thank you, David. Basically the points that you would like to highlight at this point is, one is when we are dealing with children, we have to examine them, and our concern is to examine them early. What is the time when you want to detect an infantile esotropia? How many months in the infancy? 6 months. Definitely by 6 months. So 4 to 6 months we would like to see that we are observing these children, and if the esotropia persists, as it is being seen in the congenital esotropia study, that if small angle deviations, if they have to self-correct, they would do by 6 months' time. If they persist, and which is usually if they are more than 30 degrees, 30%, then you would have to operate them. So earlier you operate, you can guarantee the binocular vision, full restoration if it's done. So one point which he highlighted was examining children, looking for the esotropia after the full correction, and secondly looking for the inferior oblique overactions if there are any DVDs may not be there at that moment of time, but infantile esotropia may have a medial rectus recession and an inferior oblique surgery done at the same time. The second point he was trying to focus on was accommodative esotropia, and there we have to see that they are fully cycloplegic, and in our Indian eyes we insist up to 5 years of age in atropine cycloplegia, so that we are having a full relaxation of accommodation, and then give the proper prescription. Any esotropia should be given a full cycloplegic prescription. If there is no esotropia, then up to 1 year, maybe up to +4 or 5 diopters of hypermetropia, you may leave uncorrected because you want the emetropization, as the newer studies are showing. Earlier, we were insisting on all case children to be prescribed fully, but now we will say that if there is an esotropia, you should give full prescription. Then again, look for any convergence excess, and as Dr. Dikvijay nicely showed you, that you have to go by the bifocal thing, that it is cutting the pupillary segment so that it is looking to the low. So these are the things that you need to focus on, that and then deal with it accordingly. Any specific questions that are there at this moment of time from the audience?
Already you were using particularly as Soma.
No, we are using homide only in older children than 6 years. Very clear. Less than 5 years of age, atropine is the only cycloplegic agent that we use.
So,
I wouldn't suggest cyclopentrate, but there are people who are fond of using it. We generally feel hometropine is much safer.
So one specific question for bifocals. I have prescribed bifocals in many children having completed dysmorphia, and the officials tell me that executor cannot be made in fiber. So they insist on giving it with glass material, which I feel is slightly dangerous, especially with hyperactive children.
I don't think that should be a reason. Because we get the executive glasses made.
No, but we have a problem making them with glass. They have a higher, they can't make it.
Generally, they have a problem.
It's going to be thicker, you will require
But
a
they
higher index.
have an edge.
Higher power, basically aphakic glasses, like for bifocal, they have a problem. But up to +4, +5, they can make in fiber.
Unless it's very
No,
high,
with an
I don't
edge.
know.
Yes, sir. Yes, I'm
But there is a
talking about
problem.
executive bifocals. They specifically say executive bifocals they are not able to make in fiber. That's right. I'm from Lucknow. That is what the officials there.
Okay, I will get into it and find out. No, generally, they are getting glasses made.
They are made in low power with near and up to +3 I've seen they can make. But I think it will make it difficult for the not everywhere.
Because mostly, see, they are going by the adult prescription bifocals, so they don't go into the executive bifocals. That's why they may be resistant. But there would be opticians who would be doing this job, I'm sure. You are from which place?
Lucknow, sir.
So we can find out. In Delhi, I think they do make. They do not register for. In Delhi, some opticians do not make, but you can get it made. It can be made. Many people they want just a deep bifocal because that is a much easier thing.
But very high powers may not make it more difficult. But yeah.
So one more question. Can I ask one more question, sir? I have a patient who is an accommodated esotrope and her esotropia for near gets corrected with bifocals. In distance, she keeps going into exotropia. I have reduced the distance correction, increased the near addition, but even then for distance, she is going into exotropia. So,
For distance, she has an exotropia, and for near, she is
with spectacles. Without spectacles, she is ESO. For distance also.
So is she over-prescribed for distance?
No, sir, she is not over-prescribed. I have under-prescribed and I have given a near addition of as much as +3. But she's controlled
Basically,
from
when you have
here.
proper correction for distance, what is the measurement? That would be your baseline measurement.
Sir, I have reduced by 2 her correction for the full cycloplegic refraction. I have reduced by +2 diopters.
And how much exo you get?
So I don't have the figures in front of me, but it's something like 10 degree exo.
10 prisms or exo.
No, sir, 10 degrees. 5 to 10 degrees.
Basically, it would mean that we are dealing with intermittent exophoria situation, which
Yes.
has a high severity.
Yes.
Then it's not an esotropia.
Sir, without spectacles, she is in esotropia.
No, without spectacles, she is esotropia, but when you give a proper correction for distance glasses,
Yes.
exo is there, no?
Yes, so I
The
have
baseline
reduced.
measurement would be 10, with a correction it would be exo.
With the correction, it becomes exo. I have undercorrected by +2 almost. Even then, she is exo for distance, but ortho for near.
I mean, what is described as giving a over minus for distance, like giving a higher, lesser plus correction for distance in such cases, but give the convergence excess correction by giving the add for near. So you have to prescribe it so that her alignment is correct both for distance and near. I think we will move on to the next topic of exodeviations.
Just one question.
Yeah.
How often do you see the recession of near point of accommodation in fully accommodative refractive isotope? Because what happens, you can't check the near point of accommodation is very uncertain. So over a period of time, when you check the children who have been on bifocals or progressives, I have realized that there is a recession of near point in nearly 30% of these patients. Is it a bifocal side effect, or inherently they have a problem with the accommodation?
No, if you are having a situation like that, what he's saying is a recession of the near point of convergence in children who are using bifocals. So he's suspecting, is it because of the bifocals that there is a recession of the near point of convergence, right?
Yeah.
So now one thing is that over the period of time, you will have to see that the weaning off is done. At what age of children you are talking about?
I am talking about, say, I have about 25
What is the age of the child?
between 5 and 7.
Yeah. So now this is the age when the hypermetropia is coming down. And you have to bring down your distance correction as well as your on seeing these children from time to time. This is not a one-off situation when you prescribe the glasses and forget. You will have to see every 6 months what is happening to the deviations, and at least the correction should be changed every once in a year. So you have to keep on modulating the glasses both for distance and the near head to check and see that the alignment is maintained both for near and distance. Okay, now can we move on to exotropia? That's the other situation which is commonly dealt with, and then on we will move to the complex strabismus. So because this is mostly advanced strabismus, but still I thought we would focus on some topics of ezo and exotropia because these are the more common things that we are getting. So Dr. Anirudh Singh, who is from the army and he has been a fellow with us, and now he is going to tell us about his presentation in exotropia.
Good afternoon. I will be speaking on the spectrum of exotropia cases. My case one, as you can see in this photograph, the girl is 15-year-old with vision of 6/6, both eyes, and in the primary position there is a evident exotropia. There is no evident A or B pattern, nor any oblique overaction is seen. And the point to focus is that for distance the PPCT values are around 55% diopters based in, and for near they are almost 45 to 48. And this shows that there is hardly a significant difference between the distance, exo and near. The AC by A ratio is around 4.5 at a great measure. And stereopsis, I like to highlight the stereopsis part, and I like to just show the video in this particular case.
So here he is basically focusing on one aspect, that the near and distance difference you always have to see. And is it significant? If it is within 10 prisms, then we will consider still as near distance disparity is not significant. Stereopsis is another thing, especially in exotropes, it will help us in finding out when to operate.
This is a video of how we do the stereopsis testing for distance. We use the random test for distance, and the patient is seated at a distance of around 3 meters. The charts, on these charts you can test the stereo acuity ranging from 60 seconds of arc to up to 400 seconds of arc. So we use polarized glasses. The patient has to be a polarized glasses, and this is based on spectrographic principle. So this is the test which we generally do in all the cases of exotropia to test for distance stereo acuity.
Because the exotropes start manifesting earlier for distance, it's usually the stereopsis for distance which is affected first. So if you are able to assess the stereo acuity for distance, you will be able to find out if they are manifesting more than often. So even if you do not have a history from the parents that is more than 50% time, because they are not working mothers, may not be able to give that thing mostly to us. A clinical test will tell us that the child is manifesting more often and affecting the stereopsis.
Now in this patient, the random test for distance showed a reduced stereo acuity of around 400 seconds of arc. Another test that is routinely done for testing the distance stereo acuity is the FD2. Now FD2 is the common term which is generally used for Frisbee-Davis distance stereo test, in which we have generally 4 geometric figures on a translucent sheet fixed onto a transparent sheet with the help of these rods. These rods are graduated from 1 cm to 13.4 cm, and one of the rods is slightly shifted forward, and the patient is asked as to which figure is forward. And in this particular test, as per the monogram, you can make the patient at a distance of around 3 meters, 4 meters and 6 meters. And you can test the stereo acuity up to almost 5 seconds of arc. So these are the two tests generally used for distance stereo acuity, FD2 and the random test. For near stereo acuity, we generally use the same as most of us must be doing, the TNO or the Netherlands organization test. And in this particular patient, it was slightly reduced around 120 seconds of arc.
So it shows that even for near, the stereopsis is getting affected. We should have intervened still earlier, before the stereopsis had already been affected.
So now with these findings of almost insignificant difference between the exotropia values of distance and near, we come to a diagnosis of basic exodeviation. Now what will be the plan? Will it be unilateral or bilateral? The ideal situation for such cases is you do a recession and resection of the non-dominant eye. Although you can still do a LR recession of both the eyes, and in case the deviation is very large, you can go in for a MR resection, but that is a controversial thing. Now, for a slight ESO of around 5 to 10 prism dactyls in the immediate postoperative period.
So whenever we are dealing with children less than 5 or 6 years, then we will never overcorrect. It's only in 6 years plus or adults that we are suggesting that an overcorrection of 8 to 10 prisms should be built in the first post-op date in order to check the regression or recurrence of.
Now the second case shows again a very large angle of EXO in the primary position with hardly any difference in the up gaze and down gaze. This was a 20-year-old child with again visual acuity of 6/6 in both the eyes. Now the point to note is the PPCT values for distance were around 95, for 75 and for near were around 55 prism dactyls. After doing the patch test and the +3 dactyl test, again the PPCT for near was the same 55 prism dactyls.
So what does it mean for the audience? What would it mean doing this test? Anybody? The diagnosis should be two divergent axis. So the attempt to find out is between a simulated divergence axis or a true divergence.
The AC by ratio in this particular case was normal by gradient method, and stereopsis was absent by Randolph test, and for TNO also cross stereopsis was absent. So the diagnosis was divergence axis or true divergence axis exotivation. Now what will be the plan in such cases? Again, whether it will be a unilateral or a bilateral management. The ideal situation for such cases is you do a LR resection of both the eyes. You can always add a MR resection of the non-dominant eye, but it should ideally be avoided. Now, what should be the aim? You should go for an ortho or an overcorrection in such cases. The aim ideally should be orthotropia, or again same 5 to 10 or 8 to 10 prism dactyls of ESO immediate postoperative period.
So here there is a little difference because it's a true divergence axis. We may have a problem of having an esotropia for near. Whenever we are correcting for the distance, there is a possibility that we may end up having an esotropia for near, and if it happens. So first thing is that we are trying to prevent that by doing a bilateral recession rather than doing an R&R in the eye, which is more productive of the. Secondly, if that happens, esotropia, you have to look for it. If there was a high AC by ratio, you could give bifocal. There could be near add given to check the esotropia further. Otherwise, sometimes we may have to do a fardinization of the medial recti to check that if there is not a high AC by ratio. So in a true divergence axis, you have to be careful not to have an overcorrection of esotropia because for near it will be still worse.
Now another spectrum. Now again we have a patient, and this is a 22-year-old female, visual acuity again 6/6 both the eyes, and now the point to note is that the PPCT values for distance was around 50 and for near was around 65. So as you can see in this particular case, the PPCT values are more for near, and even after doing a patch test and a +3 dactyl test, the PPCT values for near remained at around 65 prism dactyls. The AC by A ratio was on the slightly lower side, around 3 by gradient method. Stereopsis was absent by both Randolph as well as TNO. So the diagnosis in this particular case was convergence insufficiency exotivation. Now such cases, what do you plan? You plan a unilateral or a bilateral? You plan both resection or resection. So ideally it is MR resection of both the eyes.
How many in the audience have done a primary MR resection? Raise hand. Oh, good. So that would be the indication. Is it? It was the convergence insufficiency type of exotropia. Now mind you, here you have to be careful. There is one situation known as the convergence insufficiency type of exotropia, and other is a fusional convergence insufficiency, which may affect anybody and maybe many of us. That means a basic deviation may be nothing. Maybe even ortho, but there is a fusional convergence insufficiency. This is different from a convergence insufficiency type of exotropia, which is the measurement showing more exo for me. Is it? So that should be clarified whenever you have this situation, that we are not mixing up the two. If there is a pure fusional convergence insufficiency, you would require to give fusional exercises, and that should suffice. Mostly you will find that they will be okay with that. But if you have a true convergence insufficiency type of exotropia, you would require to operate or give prisms for me.
In such cases, be orthotropia or previous slight undercarriage. Now this is the fourth spectrum of case, and here again you see a large exotropia in the primary position, and you notice a peculiar A pattern. Davidson, and if you notice the up gaze and the down gaze, there is a A pattern also.
Go back. And other thing which you should focus is what is happening in the adduction. When the eye is adducting, there is a dipping down. There is a hypotropia of the adducting eye. Now that is indicating that there is a superior oblique overaction. So whenever you have an A pattern, first is you confirm that it's a true A pattern. And that will be the measurement in seeing that there is definitely more than 10 prism difference. Secondly, look clinically that there is a hypotropia of the adducting eye, indicating a superior oblique overaction. Not all A patterns will have superior oblique overaction. So don't take it for granted that all A patterns will have superior oblique overaction. It's only about 80% of such cases which will have superior oblique overaction. Only those cases you will have to do a superior oblique steepening procedure. Otherwise, it may be a shifting of the horizontal recti that is being advocated for a A pattern.
In this particular child, the measurements were 55 prism diopters for distance. For near it was around 45 prism diopters. The up gaze was 50 prism diopters and down gaze was 65.
So 15 prism, right?
So almost 50 prism diopter difference. After class test and plus the diopter test, the PPCD for near increased to 55, almost the same as for distance. And the AC by ratio in this particular case was on the higher side, around 8 by the graded method. And stereopsis for distance showed around 200 seconds of arc. ENO was 120 seconds of arc. So with this, we come to a diagnosis of pseudo-divergence excess type of exodeviation with an A pattern in this particular case. So the plan for pseudo-divergence excess should be ideally a recession and resection of the non-dominant eye, and for A pattern we do a PTS. The aim should be either aim for orthotropia or a slight overcorrection of 8 to 10 prism diopters in the immediate post-op period.
Thank you, Dr. Anand. So here we have presented a spectrum of exotropia. This is only to impress upon you that whenever you have an exodeviation, look into more details. What is the type of presentation? Is it a near distance disparity that you are having? Is it an up and down disparity, A or B pattern that is there? Because each one has to be targeted differently. Or is it that there is a high AC by ratio? Many a times you may think that the AC by ratio measurement is only done for esotropia. Even exotropia, the AC by ratio measurement is important and it will change your management. So that was the idea of having this presentation. Yeah. Thank you, Dr. So now we move on to the third Shweta, who is going to tell us about how we deal with the cases of Duane's contraction syndrome, a very common variety which we presented to us as a statistic.
Presented with left face turn, she had an exotropia of around 50 million diopters in the primary position. There was left eye abduction deficit as you can see there, and there was mild retraction of left eye on adduction, and there was stereopsis of 70 seconds of arc with face turn. So the diagnosis is clear-cut. She was a left eye exotropic Duane's contraction syndrome, classic variety because there was no normal LR activity, and mild to moderate variety because there was total difference and MLS LR2. Before going ahead, just a word about Duane's. In Duane's, when the LR is supposed to get supplied during abduction, it is having no supply, and when it is not supposed to get supplied during adduction, it is getting misinnervation from medial rectum, thereby having co-contraction of both the muscles. So the goal of management in the case shown was to correct the face turn and to get rid of the narrowing of alveolar fissure on adduction. So we did a FTT of left eye and first eye for MR. So we did a left eye MR recession of 4 mm. Her face turn got corrected and she achieved stereopsis of 70 seconds of arc in primary position. This case was a similar case with classic variety, mild to moderate type, but she was different from the first case because she had a larger face turn and she had a larger amount of esotropia in the primary position than the first patient. But here we did a rather smaller amount of recession of around 4 mm. So the message is that it is not the amount of face turn or esotropia in primary position which determine the amount of
So now the question is, why only minimal amount of MR recession should be done in dual retraction syndrome? First of all, you are not going to improve adduction. And the second thing is you will only worsen adduction. And you can also land up in a more difficult situation of synergistic divergence. Like this child was a case of ESO-DRS, but when we did an MR recession of around 5.5, we landed up in a synergistic divergence. Now you can see that in dextrogate, left eye is showing abduction. So it was a case, so he landed up with synergistic divergence. Then we had to do an LR recession of left eye 8 mm, and thereby the thing was corrected. This is the third patient. She was a 16-year-old girl with abduction limitation of right eye. There was, in the primary position, there was 12 to 14 diameters of esotropia. There was no retraction of globe and stereopsis of 70 seconds of arc with face turn. So she was a case of right eye esotropia. So we did a FDT for right eye MR, which was found to be free. So we did a MR recession of the good eye, that was left eye, about 6 mm, and her face turn got corrected, and she achieved 70 seconds of stereopsis in primary position. So now the question is why good eye can be operated. What is the rationale behind it? So when the good eye is operated, the MR is recessed, the fixation units of the good eye will give the extra stimulus to the medial vectors. Now medial vectors, by the Seddington's law, LR will be inhibited. The good eye LR will be inhibited, and by Hering's law, it will give less supply to the medial vectors. Now when the medial vectors is giving lesser supply, the anomalous LR tone, which is going to the lateral vectors of the DRS eye, will be inhibited. So thereby the anomalous LR tone in totality it will be decreased. But always remember that MR of the good eye should be recessed only in the case when in the DRS eye LR is dead. But if you do MR recession of good eye, in case when there is abduction of the DRS eye, that is lateral rectus is abducting, then you will land up in exodeviation. So this is the comparison of pre-op and post-op photograph of the same patient. This was another patient. She had a right-sided face turn. She had an esotropia of around 20 prisms after primary radiations. She had a right eye retraction in primary position, which was increasing on adduction. There was upshoot of right eye on ego elevation, and she had a 70 seconds of arc with face turn. And she had also inferior oblique overaction, which was confirmed on fundus extortion. So the diagnosis was right eye ESO-DRS with upshoot with inferior oblique overaction with ESO. So she was a classic variety, moderate to severe ESO-DRS. So the goal of management in this case was to correct the face turn, to get rid of retraction of globe and narrowing of alveolar fissure on adduction, and also to get rid of upshoot and downshoot. So what we did over here, we did a differential recession of medial rectus and lateral rectus. MR recession of around 4 mm and LR recession of 7.5 with wide splitting, and also the right inferiorly modifying ENN. We should always remember that we should never resect in case of DRS. This was a comparison of pre-op and post-op photograph. You see that there is improvement in the retraction, the upshoot has decreased, and the patient was quite happy. Now, what are the things we must assess before taking up a case of DRS for surgery? The pulse of magnetic, we should check for the normal LR. That can be clinically checked by limitation of adduction. And how much is the anomalous LR? That can be checked by limitation of adduction. There's retraction of globe, how much is the retraction of globe in primary, adduction and abduction, and the force degeneration test. Now we should also check for how much is the face turn, upshoot, downshoot. FDT should always be checked for MR and LR to look for the contracture of muscle in ESO and ESO-DRS. And balancing of the force is very important, especially in children when you can't do adjustable, you can adjust on table, and in cooperative adults you can of course do adjustable. This was the
Let's stop short here. So basically ESO-DRS can be presenting in various forms. Each type of ESO-Duane retraction syndrome is not the same. So you cannot apply the same regime of surgery. As you have seen, if you think that 4.5 mm should be good enough for the ESO deviation, which was for 30 prisms, and that was done, you had a synergistic divergence. Is it clear to all of you why that happened? Because there was a co-contraction. You have weakened the medial rectus. The lateral rectus is now spot-free to act, and it will cause a exodeviation much more. In fact, all cases of ESO-DRS, if you look carefully, will always happen. There is a co-contraction. There is a lateral rectus working during adduction. You have weakened the medial rectus, then the lateral rectus alone acts or is having an edge, so we call them exo in adduction attempts. But we are limiting it only to the point that it is acceptable and not cause more than exo that can be fused. Okay? So this is something which we need to understand. It's not like any other ESO deviation that you will see happy to do just an MR recession and be happy. It will create a problem of an exo defect. So you might have to balance if there is a co-contraction which is more than normal or more than the desirable that you want. You might even have to do an LR, lateral rectus recession, maybe along with a Y-split if there is a severe co-contraction. So as she has said, there are variable things that you will have to see. Is there normal LR tone or there is an abnormal LR tone, lateral rectus tone? And thirdly, how much is the co-contraction? These are the three variables. And fourth is, on table, how much is the amplitude? So there is a variation of the tightness of the medial rectus that you will see. If suppose you find the amplitude is free, and in that case there is in such a situation, you may not do a medial rectus recession at all. Then you may do, for the ESO correction, the medial rectus on the normal side. It may be more effective to do it. Okay? Because it will correct the ESO deviation and it will also reverse the process of anomalous innervation. But in ESO DRS, we are not able to tackle the problem still. The real problem is anomalous innervation of the LR, lateral rectus. But if you do a lateral rectus, and in the presence of a tight FPT of the MR, you have to do a medial rectus also, then you have already tied your hand that you can never do a vertical rectus transpositioning because the risk of anterior segment is keen. But ideally for a DRS, as we are now learning, the basic correction would be to isolate the lateral rectus, which is the basic problem. The basic problem is anomalous innervation to the LR. So now we move on to the ortho and the exo DRS to understand the DRS problem in little more detail.
She was a case of right eye ESO ortho DRS. Clinically she looked like ortho, but on PVCT there was small amount of ESO which was coming around 10 prism diameter. There was some normal LR activity, as you can see that there was only -1 LR adduction deficit, and there was a retraction of the right eye on adduction. So what we did over here, we did a differential MR and LR recession, MR recession of 5.5 and LR recession of 10 mm with Y-split. And she achieved both the improvement in retraction of lobe as well as in downshift improvement. This was a case of exo-DRS, left eye exo-DRS. He had an exotropy of around 15 degrees in primary position, and there was retraction of lobe on adduction, and also there was downshoot. So what we chose to do was LR periostal. We did a FPT which was tied for LR. We fixed the lateral rectus to the periosteum, and we did a partial vertical recti transposition with a cross action and on an adjustable basis. And the patient got his exotropia got corrected, and retraction improved and downshift also improved. This was another patient. She had right face turn and an exotropia of around 15 degrees. There was -3 adduction deficit, as you can see over here, and there was also upshoot and -1 adduction deficit, and there was a reduction of left eye on flexor gaze. So we did supramaxima. This is another form of another kind of tackling of the exo-DRS. Normally in children, we prefer to do supramaximal recession rather than periosteal fixation. So we did a supramaximal recession of around 15 mm with hand back, and we were able to correct both the exotropia in primary position as well as retraction of lobe and upshoot. And her face turn also got corrected. Now this is the last case which I will show here. He was a case of again right eye exo-DRS. He had a right face turn. He had an exotropia of around 15 degrees, and right eye he had adduction deficit of -1, and there was retraction with upshoot of right eye and ego gaze. And here we did a periosteal fixation along the split APRT, but since the exo was very large, we did a LR recession of the good eye as well, around 8.5 mm. In this video, I will show how much is the abduction range which we achieved after LR periosteal fixation and partial DRT. You see that the patient right eye is abducting quite nicely after the partial procedure for exo-DRS. Thank you so much.
The lateral rectus has been hooked here. We are using the 5-0 echelon suture. Adrenaline has been applied, and now you are seeing the periosteum area. And there is thin fascia which is there, which is being cut, and you can then examine the periosteum which is shining behind, and then you pass your. This needle has been curved artificially a little more by using the needle holder, so that you have a larger curve, and you can pass the. Now the lateral rectus has now been lateralized to the lateral periosteum with the help of the 5-0 echelon suture. There is a saying, if you have a bad element in the society, how do you deal with it? There is one way that you can put him in prison, the other way is hanging. We don't believe in hanging. So there are people who do total extirpation of the LR. There are people who use the tonsil snare and remove the whole lateral rectus. I do not advocate that. What we can do is put the lateral rectus into the imprisonment forever to the periosteum. So this is how this is done, and then you have to put a compartmentalization by using the 8-0 vital sutures to make a separate compartment for the lateral rectus to be there isolated and not interfere with the abnormal activity on the globe. So this is a very effective procedure, especially for exo-DRS cases. Any queries up to now? Huh? No, we are doing a limbal incision.
That's okay.
Yeah.
When you are just taking the so how far are you from that?
No, the periosteum is always going to be a little more posterior. So if you, it's like sort of, it will go back behind. So you will just put 3 millimeters from the edge of the lateral margin. You will be feeling the bone from inside. We haven't gone through the skin approach. We have gone basically from the subconjunctival root only up to the periosteum, and then cleared that area and passed by the needle a periosteal entrance.
So why is it that in children you prefer supramaximal LR recession rather than?
Okay, basically in children it's a growing stage. So we are avoiding in very small children. If we have to deal with exo-DRS, then we are avoiding doing a periosteal fixation and doing a supramaximal recession of about 18 or 20, 21 mm lateral rectus recession. Yeah.
How often do you do wide split of muscle, either LR or MR, without recessing?
Never.
Without recessing?
Without recessing the LR, I never do a wide split.
Okay.
Because the simple reason is, whenever you do a wide split, there would be a extra tension that you would have in the lateral rectus, and you always should do a little bit of recession in order to counter the tightening that you will have created.
Okay, my question I think come across properly. What I'm saying is, in to avoid the co-contraction, when you are tackling one muscle, you can do the other muscle way away split and attack at the same place. Like in the situation of DRs where you are tackling both medial and lateral rectus. In such a situation, what I do is, I tackle the medial rectus, says there is isotropy. I tackle the medial rectus, what I do for this. But the lateral rectus, I just do a Y split and reattach it at the same point where it is. Thereby, I reduce the co-contraction of the lateral rectus and prevent later exodeviation.
Yeah, but by doing only a Y split, you are only tackling the co-contraction.
Yes.
Right?
Yes.
But unless you have added a recession, you might still have a retraction on adduction. See, the upshoot and downshoots have been limited. But since you haven't reduced the co-contraction as such, there will be still a retraction in adduction. Get it?
The Y split does reduce the co-contraction.
It reduces the upshoot and downshoot. It only prevents the slippage of the glove. It doesn't change the innervation. It doesn't change the co-contraction as such, which is there in adduction. Simple, because if you haven't done the recession, how will the lateral rectus get weakened?
No, but we have cut the insertion of the muscle. Thereby, the reflex arc is reduced, and therefore, the muscle does not have as
No,
much.
you will find it if you look carefully, you will always have a retraction in adduction in these cases, although upshoot and downshoot will disappear, I agree. So it is only tackling one of the aspects of waist traction. So I think we had a little bit of music also in between to wake you up, and now we move on to the next topic, and that is a little more complex problem that we deal with. In the meantime, the scientific committee tells us that we are listening and you need to give a feedback to us. So let's have, how do we deal with the concerned Turner palsies? You are aware of this situation, that it may have a various types of presentation. In fact, it is the most variegated presentation that you have in these cases. No, it is the sound of laptop is sound of. If you are lucky, you may have a situation when a simple R&R would work. But otherwise, you may have to do a periosteal anchoring of the globe. That means we are going to fix the globe on the medial periosteum. So this is a little different than what we have seen for the lateral rectus periosteal fixation. Don't get confused. In Turner palsies, as we understand, it's a large angle exodeviation. The lateral rectus is very strongly contracting. You would have to weaken the lateral rectus first of all. Secondly, just by weakening also, and mind you, when we say weakening of the lateral rectus, how much are you thinking? How much recession should you do anybody? For a lateral rectus weakening in Turner palsy? The numbers, anybody?
16.
Huh?
16 to 18.
18 to 20 mm? Millimeters. Yeah. So something like 18 to 20 millimeters of lateral rectus recession from the insertion side. Okay? So that much is what is required because lateral rectus is so strong and it is unchecked. If you do less than this, you will always have an exodeviation with previous thing. So that is one option, that you can do a supramaximal LR recession, but still we find the exodeviation. So what do? You can then do a periosteal stitch of the globe to the nasal side. And this is what we described, and you could anchor the globe on the medial side. These are the steps which are being described. And the first one is describing the common DCR approach. Through the skin approach, you can reach the side of the posterior ciliacrimal crest and pass your suture, and then bring through the subconjunctival root these epimont sutures, and then fix the globe. So that was the first type that was done. Secondly, we started doing a pre-curricular approach. You might have seen a video which Dr. Louis presented in the morning session, in which there was a pre-curricular incision through which we went in order to avoid the skin incision. That is the second approach. You can go and then stitch your needles in the periosteum, bring them subconjunctival, and then fix the globe to the medial surface. But then we wondered that basically you have to do first the lateral rectus recession and secondly the anchoring of the globe. The third possibility is why not just do the lateral rectus periosteal anchoring. So just like in exo-DRS, you can also do large angle exotropia, and in the bottom 9 cases you can see that after the lateral rectus periosteal anchor, you are still left with an exotropia. So even though you remove the lateral rectus altogether, there is still an exotropia, and you need to do something for that. And in this you can add a leash of the middle rectus. Even though it may have no innervation, it may act as a leash of MR section of 8 or even sometimes a little more 8 or 9 mm. Many a times still you will have an exotropia coming in some cases if you have a lateral rectus still in position. But if you remove the lateral rectus altogether, a 8 mm resection suffices. Okay? So this is one way, as you see here, the exotropia is nicely corrected, and he may have some vertical movements like in this case, but otherwise the exo which was marked after the LR periosteal anchor and the MR resection, he seems to be reasonably okay. The second situation sometimes we deal with is a synergistic divergence. Another variant of a third nerve palsy in a way. It's a congenital neuropathic third nerve palsy in which there is an aberrant innervation. What is happening here? You see the right eye abducting, the left eye is adducting, fine. But when on the other side, when he is abducting, there is a simultaneous abduction. There is a much more abduction of the right eye when the left eye is abducted. That means in levo version, the exo is much more. The extra innervation is coming to the right LR on attempted levo gaze. Why is this? The medial rectus innervation is now actually going to the right lateral rectus. So there is an aberrant innervation. We are going to deal with some more such situations now. Now this case is a little unusual. What you see here again here is an exo deviation in the primary position. Can we have the laser pointer please? Excuse me. What you see here is a mark in the primary position, there is a marked exotropia, and there is a simultaneous abduction also, a synergistic divergence. But there is something more here. On attempted adduction of the right eye, there is also a downshoot. Now, how do you deal with this situation? You see here there is a synergistic divergence, as you can see here. But on attempted adduction here, now there is a downshoot of this. There is a hypotropia of the right eye, which is not here. But suddenly when this is an extreme levo gaze, you find that this eye is dipped down. When you look at the right side, the eye is fine here. There is hardly any vertical deviation. This eye is moving up and down. So it may not be a fibrosis which is restricting the movement. It is basically some problem with a change in the innervation, or maybe some co-contraction. Somebody might say that on attempted adduction there is a co-contraction, but it doesn't show up here because in co-contraction if you call there should be retraction of it. In a co-contraction first would be a retraction of the globe. There is no retraction. In fact there is a widening of the pelvic aperture here, and on attempted adduction there is a downshoot. So what would you think of? Here there is a synergistic divergence and probably an innervational downshoot of the right eye in levo gaze. We tried to look into the fundus and we saw in the primary position the eyes were okay, but in adduction there is an extortion going on. Why is there extortion coming in? Possibly there is some extortion because of in the downshoot the inferior rectus is causing it. The MRI was done. On the MRI, in the dextro gaze, you see there is the increase in the width of the lateral rectus. Compared with the primary gaze, you can see here in dextro gaze. Both there is a simultaneous lateral rectus activity. Right? And when the person is made to adduct the right eye, there is an increase in the, see this in the primary position, you see here. There is a sudden contraction of the inferior rectus which is apparent. So the dynamic MRIs are indicating that there are two problems here. Both are innervational. The left eye synergistic divergence and there is a right eye innervational downshoot. Is it clear? So these are things, and then we fed the tuck of the right eye inferior rectus under topical anesthesia when we are doing. If you disinsert the inferior rectus and then you ask to adduct, then this eye will not have a solve. So what should be done? If somebody heard the morning session, what was the message that was given? So you can transposition the inferior rectus to the lateral also done in order to prevent the hypotropia that was occurring. So it improved, but not still there was an exotropia which is still there, and you may have to do a little bit of advancement on this inferior. So first case when we did, we found that post-operative there was an exotropia still. Then we revisited and then we put a posterior suture on this transposed inferior rectus to increase the vectorization force. So this is a pre-op picture, this is a post-op of the first case. The second case which came similar to us, then second time we were more educated. And so this time we got a better correction in the primary position here. The hypotropia has been reduced. Compared here, this side, much more severe than the first case. And this is afterwards the reduction. And this simultaneous abduction problem has been rectified as well as the innervational downshoot. This is the third case of a similar kind. So what we see, such cases, we have to individually see what is the problem. What is the abnormality that is going on? We talked about Duane's infection syndrome. Dr. Shweta presented a battery of cases in which she was telling us that when there is an absent LR activity, there is the possibility of a misinnervation from some other extraneous factor. Nature abhors vacuum. No? So something else will come up in the embryonic phase when some innervational problem is happening. Misinnervation is not rare. It can happen very easily. Similarly, there are situations when there is a congenital absent MR supply, there is a misinnervation of two kinds. One is a synergistic divergence and other is a innervational downshoot.